Bismillahirrahmanirrahim. Now we are talking about the Parkinson disease. The Parkinson disease. Parkinson disease. The Parkinson disease occurs as a result of the imbalance between the dopamine and acetylcholine. Parkinson disease occurs as a result of decrease in dopamine and increase in acetylcholine. The decrease in dopamine is due to the destruction of the dopaminergic neuron in the substantia nigra pars compacta and the degeneration of dopaminergic neuron in the substantia nigra pars compacta. A result of this, there is deficiency of the dopamine and the acetylcholine pathways increase. The dopamine have the inhibitory effect in the dopaminergic and acetylcholine have excitatory effect. Dopamine have inhibitory effect and acetylcholine have excitatory effect. Because of this reason, the Parkinson disease develop. The receptor for the dopamine are D1, D2. Receptor for dopamine are D1. D1 are present in other system and D1 are GS coupled and D2 are D2A and D2C. D2A are present in the nigrostriatal tract and D2C are present in the mesolimbic tract. D2C are present in the mesolimbic tract. The sign and symptom of the Parkinson disease are signs and symptoms of Parkinson disease are bradykinesia, muscle rigidity, in resting tremor. There is resting tremor in the Parkinson disease. The pathology is the degeneration of the nigrostriatal dopamine tracts with imbalance between dopamine and acetylcholine. there is imbalance between dopamine and acetylcholine, and there is degeneration of nigrostriatal tract. The nigrostriatal tract due to a receptor for this is degenerate, and there is imbalance between dopamine and acetylcholine. Now we do the pathway of the dopamine and acetylcholine. This is the dopamine, and this is the acetylcholine, and this is the dopamine receptor. There is the receptor for the dopamine in the dopaminergic pathway. In the dopamine have the negative inhibitory effect under these dopaminergic pathway, and other is acetylcholine. Acetylcholine have the stimulatory effect on this pathway, and the result of this, the GABAergic neuron. This is the GABAergic neuron in the striatum. GABAergic neuron in striatum. As a result, when the Parkinson disease occurs, this inhibition of the dopamine is not occur. This is not occur, and acetylcholine regularly releasing acetylcholine on this receptor. There is imbalance between the acetylcholine, that acetylcholine increase, and dopamine decrease, and in this way there is bradykinesia and muscle rigidity and resting tremor occur. Now we will discuss the type of drugs that inhibit the pathway. The imbalance between this is managed by the drugs. Number first is L-DOPA, that is levodopa, increases the synthesis of dopamine. There is enzyme called monoamine oxidase B. This inhibit the dopamine synthesis. This inhibit the process. Now this inhibit the synthesis of dopamine. Now we inhibit this enzyme MOAB in the dopaminergic neuron, in the dopamine receptor. For this, we inhibit this enzyme by the drug called selegiline. Inhibit this enzyme by the help of selegiline. And another drug that this is the dopamine releases. And another drug that stimulates the synthesis of dopamine and this dopamine pathway, that are called dopamine agonists. Or dopamine synthesis, that is called levodopa, it increases this dopamine. It increases actually dopamine. This drug is called levodopa that increase the synthesis of dopamine. Increase the synthesis of dopamine. Another drug we will discuss that block this pathway, there is increase in the acetylcholine. This pathway is inhibited by the M blocker that decrease cholinergic activity. This pathway is inhibited by the muscarinic blocker or M blocker. Another type of drug we will discuss that is called dopamine receptor agonists. There is dopamine receptor agonists. The dopamine receptor agonists activate the dopamine receptors. Dopamine receptor agonists activate the dopamine receptor, the DOPA receptor, activate the dopamine receptor. There are the four mechanisms in which we will treat the imbalance between the dopamine and acetylcholine. Number one is the levodopa, that is called levodopa, increase the synthesis of dopamine in this way. Levodopa, we give levodopa. Levodopa is a prodrug. That converted to dopamine by the aromatic amino acids. Levodopa is a prodrug, that is not drug. Prodrug that can be converted into dopamine by the help of enzyme called aromatic amino acid decarboxylase. Aromatic amino acid decarboxylase and dopamine in this way help. But the levodopa can cross the blood-brain barrier. Levodopa cross the blood-brain barrier. Levodopa can cross the blood-brain barrier. This is the levodopa. They can cross the blood-brain barrier. But some of the levodopa converted into dopamine by the help of aromatic amino acid decarboxylase into dopamine outside the brain, in the periphery, and there is insufficient amount of the dopamine, the levodopa, that enter into the brain. So we can inhibit this enzyme, that is aromatic amino acid decarboxylase in the periphery. We add carbidopa. We add carbidopa into the levodopa. There is sufficient amount of the levodopa to enter the blood-brain barrier. In the levodopa in the blood-brain barrier, they can be converted into the dopamine by the help of amino acid, aromatic amino acid decarboxylase into dopamine. MAOB metabolites it, and then MOAB metabolites it. But there is also inhibited by the MAOB inhibition in the brain into not to convert to the metabolites. They are also inhibited this pathway. The other drug is tolkipon, siligilene, bromocriptine, pramipixole, imintadine. But first we will discuss the side effect of levodopa. Levodopa has on-off effect. Levodopa side effect. Side effect. The side effect of the levodopa is on-off effect. On-off effect. Psychosis, hypotension, and vomiting. And the second number drug is dopamine receptor agonists. But we will discuss the tolkipon and entacapone. That is tolkipon and entacapone. Entacapone and tolkipon. The capones, when the capones are coming in their name, there are COMT inhibitor. COMT inhibitor. COMT converts L-dopa into 3-O-methyl-dopa, is a partial agonist at the dopamine receptor. These drugs inhibit COMT and enhance the levodopa uptake and efficacy. These drugs inhibit the COMT and enhances the levodopa into uptake the efficacy. But the tolkipon, tol means hepatotoxic. Tolkipon are hepatotoxic. The toxicity of the tolkipon in the liver. And entacapone is safe. Entacapone is safe. So this work there is levodopa enter into the blood-brain barrier and they convert into 3-O-methyl-dopa. They can be converted into 3-O-methyl-dopa. The conversion of levodopa into 3-O-methyl-dopa is inhibited by COMT enzyme inhibition. That is, capones occur in their name, tolkipon, entacapones, and there is direct the dopamine increases in the brain. Dopamine increases in the brain. There is no conversion of the levodopa into 3-O-methyl-dopa by the help of this enzyme. Other are siligilene. Siligilene are MOAB inhibitor. They are selective inhibitor. Initial treatment they will give. Side effects are dyskinesia, psychosis, and insomnia. MOAB inhibition occur at this. And MOAB in the dopaminergic pathway inhibit the synthesis of dopamine, but we will inhibit this enzyme. There is no further inhibition of the dopamine synthesis. That are siligilene, MOAB inhibitor. MOAB inhibitor. But the side effect are this is dyskinesia. Side effect of capones. Side effect of MAOB. MAOB, that is siligilene. That is side effect is dyskinesia. Dyskinesia, psychosis, insomnia. There is also psychosis and insomnia. Insomnia occur also. The other drug is bromocriptine. Bromocriptine we cannot use nowadays for the Parkinson disease, they use for hyperprolactinemia and acromegaly. Bromocriptine. Bromocriptine nowadays we use for hyperprolactinemia, and psychosis. We use this. They are the dopamine receptor agonists. They act on the dopamine receptor. Other example of the dopamine receptor agonists are pramipixole and ropinirole. Pramipixole and ropinirole but they also use and bromocriptine nowadays not used. They are mainly used for hyperprolactinemia and psychosis. Pramipixole and ropinirole are used. They are the dopamine agonists. So they are the dopamine agonists. There is the dopamine receptor agonists activate the dopamine receptor. The example is pramipixole and ropinirole. Bromocriptine is also, but they are not used nowadays. The other are drugs. They decrease ACH drugs to decrease ACH, acetylcholine, because they are in the Parkinson disease there is high acetylcholine. This is inhibited by the drug called benztropine and trihexyphenidyl. Benztropine and trihexyphenidyl. There is dopamine synthesis or M blocker called muscarinic blocker. They decrease the synthesis of dopamine. There are M blocker that increase the synthesis. Normally there is increased synthesis of acetylcholine in the Parkinson disease, or there is drug that decrease the synthesis of acetylcholine. They are called M blocker. The example of this is benztropine. Example is benztropine and trihexyphenidyl. Trihexyphenidyl and benztropine, they block the activity of acetylcholine, but the side effect of this, they decrease the tremor and rigidity, but have a little effect on bradykinesia. Side effect of this is atropine-like side effect. Atropine-like side effect of these drugs. Other drugs are amantadines. Amantadine are antiviral. They also block the muscarinic receptor. They block the M receptor, and they increase the dopamine release. They increase the DOPA release, but they have also atropine-like side effect. Or side effect of this is also atropine-like side effect. Now this cannot be used because of the side effect. So a quick review. Dopamine is in the nigrostriatal tract, helps to regulate the kinesis, the activity, the movement by inhibiting the GABAergic and cholinergic neuron. By inhibiting the GABAergic, the inhibitory action of this and cholinergic neuron. This is inhibited. This not occur normally, and they occur in sufficient amount, not in the big amount. The laws of dopamine neuron, the laws of the dopamine neuron in this pathway in the neurostriatal tract causes the excessive acetylcholine activity, and there is loss of activity and less activity in the dopamine, and there is imbalance between dopamine and acetylcholine, and Parkinson diseases occur. The agonist for dopamine may also cause dyskinesia. Agonist for this, the dopamine also cause dyskinesia when more agonists are used. The antagonist, dopamine antagonists that block this activity. The antagonists decreases of psychomotor function. In the hypothalamus, there is also dopamine release into the pituitary. Dopamine also released in the hypothalamus in the pituitary. Dopamine also released in the hypothalamus in the pituitary to decrease the prolactin release. Dopamine also released in the pituitary gland to decrease prolactin secretion. And when we use dopamine agonists, that is bromocriptine, to treat hyperprolactinemia, because dopamine decreases the prolactin level. Dopamine agonist can be used for hyperprolactinemia. That is called bromocriptine. We use for hyperprolactinemia. Bromocriptine is used for hyperprolactinemia to decrease the prolactin level. The activation of dopamine receptor in the chemoreceptor trigger zone increases emesis. The role of dopamine in chemotrigger zone. They act also in chemotrigger zone to omit emesis. So we will use the dopamine. Patient may cause vomiting. And the antagonists have the reverse effect that block the chemotrigger zone. Antagonists have reverse effect in the chemotrigger zone, so they are anti-emetic. Dopamine agonists are vomiting, they act on the chemotrigger zone, but antagonists are anti-emetic. They can be used anti-emetic. The other drugs we will discuss in the next lecture.